Hi, so now let us start with this next program. We'll talk about the diarrheal disease program and cholera together. I think we all know that the father of epidemiology is Dr. John Snow. But the father of public health is a disease called as cholera. On 7th of September 1854, Dr. John Snow, he broke the handle of that Broad Street pump. There was a water pump, and he broke the handle just because he thought that we found the reason that why cholera happens in people. So he was the first person who drew a spot map and postulated that cholera could be probably a gastrointestinal infection compared to what was thought earlier was bloodborne infection, or was it through air, or it was a neurological disease. So a lot of hypotheses were there. So he gave us the understanding of public health, and that is why the public health disease, the father of public health is cholera, and father of epidemiology is John Snow. Let us have a few words about cholera disease as such. In all the communicable diseases before as well, we have talked about the source or the agent factors or the reservoir factors. We talked about the incubation period, the communicability factors, and the special points to remember, and immunity and prevention and control. So let's talk about the source or the reservoir in this disease, that is cholera. The agent factors that you need to remember in cholera could be of two types. We can have O1 or we can have O139. O1 can further be of two types. We can have a classical O1 cholera or an LTOR O1 cholera, and both can be of Ogawa, Inaba, or Hikojima types, Hikojima serotypes. So they both can be of Ogawa, Inaba, or Hikojima, classical or LTOR. I think we all should know that which one is most common cause of which cholera serotype is most common in India. It is the Ogawa serotype from LTOR family or the group, and that is the most common cholera that we have in India. Talking about the source factors or the agent factors more little in detail, the reservoir of cholera is of course a human, needless to say. Talking about the source factors, the source could either be a case of cholera or it could be a carrier of cholera. Do you know that MCQs now start? Do you know that out of all the cases of cholera, 75% do not develop features of cholera or do not develop the disease as such? They either stay as carrier stage or they may stay as subclinical stage. So carriers are very important in cholera. How many types of carriers we can have in cholera? We can have many types. Almost every type of cholera carrier stage is existent in cholera. Carriers can broadly be classified into temporary carriers, or we can have a permanent carriers or chronic carriers, right? Chronic carriers or temporary carriers. So temporary carriers could be like we can have a contact carrier. We can also have incubatory carriers. We can have convalescent carriers, contact carriers, or chronic carriers. We can also have something called as a healthy carrier. For more details on what is a carrier stage, what is a healthy carrier stage, please you need to visit the module on concept of disease and epidemiology and infectious disease epidemiology, and there we have discussed much in detail that why does the carrier stages happen at the first place. But over here, point for you to remember is that each of the carrier stage may start spreading the disease. So please remember that all the cases may keep on spreading a disease. Specifically talking, the cases can spread the disease by around 8 to 10 days. They will keep on spreading the disease. That is the communicability phase of the case of cholera. If you talk about carriers like chronic carriers, they may spread on disease, keep on spreading for weeks to months. And that's the reason that's what I want to explain over here, that the reason that why cholera happens in the community is because of two things. Either it is because the people are spreading, or because it is the water is spreading. So water, even if you stop water contamination with cholera, there is an epidemic tail which will keep on happening. Why that tail happens is because you have so many chronic carrier stages. You have healthy carrier people who will keep on spreading the disease and maintain the infection in the community. So please remember, these are very important types of carrier stages which happen in the community. Also, I would say that this can be an MCQ again, which is more important as a source of spreader of infection? Is it a chronic carrier or a healthy carrier? Please remember, for cholera, it is the temporary carriers which are more important than the chronic carriers. The temporary carriers are more important for spread of infection than chronic carriers, because chronic carriers are particularly rare in cholera, but they do happen, and that is the reason there is a type of a epidemic tail phenomena which keeps on happening. Next is, so we have talked about the S features. Now let us come to the I. I stands for incubation period. The incubation period is 1 to 2 days. Maximally, it is up to 5 days. Next is, what is the communicability points? This is again a feature for MCQ over here. A lot of MCQs can come from why do cholera cases spread at the first place. So try to understand, there are two features over here: period of communicability and the mode of transmission. The period of communicability can range from, just now we talked that it could range from as low as 7-10 days in cases, like 8 to 10 days for cases, or as long as weeks or months in case of chronic carrier stage. If I just show you the infectivity potential or the infective period for each of these stage, it's not actually a carrier stage, but anyways, case of cholera can spread from 8 to 10 days. The incubatory carriers, 1 to 5 days, that's very short time, that's fine. But convalescent carriers, they will keep on spreading for 2 to 3 weeks. What is convalescent phase? After the cholera disease is over. So during that phase, people keep on shedding the Vibrio cholerae. Even for contact carriers who are very few, like people who will arise from the subclinical cases, these would be classified typically as contact carriers or the healthy carriers. So they are just the contact. And chronic carrier stage is rare, but it may keep on spreading from months to years. So that is a point to be understood, that communicability period has a wide range. It could be as early as 7 days to 8 days. 8 days in cases of cases, and it could spread over to weeks or months in cases of chronic carriers. So keep this in mind. Next is, what is the mode of transmission? Mode of transmission is primarily waterborne. It could also be a foodborne or a fomite-borne or a direct contact. But all these have lesser potential of transmission, more potential. It's essentially a waterborne disease, right? If you understand this, now let me come over and take to you to the special points which you need to remember for your exam. Please remember that out of all the cases, I told you that more than 75% will not develop disease. Only 25 to 30% is going to develop the disease. So 25 to 30% will develop disease. Out of this, roughly 15 to 20% may develop severe dehydration, and that is the reason that cholera is a serious public health problem. Any person who will develop a case, who will develop a feature, will inevitably be a severe or serious type of dehydration. Mild cases, whoever are the mild cases, remaining like 5-10% are the mild cases as well. The mild cases may usually recover. Recovery is a rule, but they will recover in 1 to 3 to 4 days. So 1 to 3 days they are going to recover, and remaining 50-20% will land up into severe dehydration. That is the understanding that why does cholera be account for as a public health problem disease. First point is that what all cases will be there, whoever will develop, they usually develop a severe infection. Second point, there is something called as the epidemic tail phenomena. What is an epidemic tail phenomena in cholera? The epidemic tail phenomena is that once the epidemic or outbreak of cholera is there, it takes a very long time for the tail to settle down. It usually, like before the outbreak, this was the level. And after the outbreak is over, the level increases. This is called as epidemic tail. It is found in cholera epidemics. So what is the determinants of this epidemic tail? The determinants of epidemic tail could be the force of infection. The force of infection could primarily be because of two things. Either we have a contaminated water source which is being going on, or we have the contacts which will keep on spreading. So both these things, the water and the contact, will lead to the epidemic tail phenomena. So please remember that till now what you have understood is that maximum cases will not develop the disease. In case a person develops a disease, they will tend to be more severe kind of things. And we also have an epidemic tail phenomena. Next is about the immunity, the prevention and control aspects in cholera. So regarding the prevention and control aspects of cholera, the first thing is that cholera is a notifiable disease. Cholera is a notifiable disease. Under the international health regulations of the WHO, under the IHR 2005 international health regulations by the WHO, please remember there are a couple of diseases which are internationally under surveillance, which are around 11 to 19 diseases, and there are certain diseases which are under the international health regulations. So they are notifiable by any case of disease has to be notified to WHO. What are those diseases? These are C, Y, P, I and another P. CYPIP. C stands for cholera, yellow fever, plague, influenza, including SARS, and polio. So these are your IHR, International Health Regulations, notifiable disease. So first thing is that notification of cholera case is of utmost importance. Second thing is there has been proven evidence of giving oral rehydration therapy plus zinc as well for all cases of diarrhea, persistent diarrhea. Third is use of antibiotics also. Antibiotics are generally advocated or recommended to be used 3 to 4 hours after rehydration therapy is installed, and once the child stops vomiting or diarrhea episodes decrease in frequency. So the antibiotics which can be tried on different, like there's no single antibiotic which has been proven that this is the drug of choice, but yes, of course, tetracyclines have a proven efficacy. Tetracyclines and fluoroquinolones and trimethoprim, sulfamethoxazole or the Septran tablets. Fourth is use of sanitation measures, where we will promote safe water supply, promote excreta disposal techniques. You have to promote food hygiene and also disinfection. This can be an MCQ that regarding disinfection. What is the disinfectant of choice? Please remember, in many areas I have told you, especially in viral disease, it is sodium hypochlorite. In this case, in cholera, it is a coal tar disinfection. Coal tar disinfectants may be used, which have a Riedel-Walker coefficient. Riedel-Walker coefficient, also called as the RW coefficient. Riedel-Walker coefficient tells you about the efficiency of the disinfectant, right? So Riedel-Walker coefficient of more than 10 is what is used in cases of disinfection for cholera. The fifth is we can also have chemoprophylaxis in place. Chemoprophylaxis. The drug of choice for chemoprophylaxis is doxycycline, to be given at the rate of 500 milligram to all adults in BD dose. In case of child, it is given as 125 milligram, again as BD dose in case of children. So in case of children age more than 3 years. So we give it for 3 days. This is the drug of choice for chemoprophylaxis of cholera. Next we come over to is one of the most important, and I think that's where the most of the MCQs also come along, that what about the vaccines in case of cholera? The vaccines are two. We can have a Dukoral vaccine or a Sanacol vaccine, which is by name of Shankol. So that's a registered trademark, Shankol vaccine or a Sanacol vaccine. The Dukoral is effective. Both the vaccines are, please remember, that's an MCQ. Both the vaccines are only 50%, approximately 50% effective. The Dukoral vaccine is only for O1 type of cholera, whereas Sancol is for O1 and O1390 type of cholera. Next is the effectivity of Dukoral vaccine will start after 7 days from the second dose. And similarly over here in Shankol, it starts after 7 days from the second dose of the vaccine. So there are 2 doses, but the point of difference which makes over here that the effectivity for Dukoral vaccine, it starts Dukoral. I have remembered do means 2, so dual thing. So it lasts only for 2 years, whereas Shankol, it lasts for 3 years. So that is an important MCQ over here. The second is Dukoral vaccine. This Dukoral vaccine, it contains a beta subunit. And this beta subunit is destroyed by the gastric pH. And that is the reason, because it contains a beta subunit, the Dukoral vaccine is mixed with some of the granules which act as a buffer which protect from the gastric pH, right? So because Dukoral contains a beta subunit or the B subunit of the cholera, so therefore it is given as oral suspension of the vaccine, plus we have effervescent granules which acts as a buffer. So they will act as buffer. Why buffer? Because it may be destroyed by the gastric pH, the Dukoral one. Whereas on the other hand, the Shankol, there is only need of oral suspension and no gastric buffer is required. Why? Because it does not have a beta subunit, right? So it is only oral suspension. Regarding the dosages in Dukoral and Shankol, Dukoral is given as 2 doses of vaccine are required, which is to be given 1 to 6 weeks apart. Whereas the Shankol can be taken as again 2 doses, which can be taken as 2 weeks apart. So usually in many areas, we are using only the Shankol vaccine because it has more kind of effectivity. It is applicable for 3 years. It is not destroyed by the gastric buffer, whereas the Dukoral was the prototype of the Shankol. And we now even have more stable vaccine that I'll just tell you, it is a Uvicol vaccine. So Dukoral, just 1 point more to go, that in Dukoral, because you have that effervescent granules which were acting as a gastric pH, this Dukoral will come in powder form which has to be mixed in water. So we say that for adults, the mixing in water should be approximately 150 ml. This whole vaccine is mixed in 150 ml of water and then taken for all the adults. And for all the children, what do I mean by children in this age group? Child less than 6 years. So anybody who's adult or more than 6 years. So all children more than 6 years or adults, they will take 150 ml of water. All children less than 6 years, they are going to take 75 ml of water, and in that they are going to dissolve this vaccine, Dukoral vaccine. Please remember that Dukoral vaccine is not to be given for age less than 2 years, whereas Shankol vaccine is not to be given for age less than 1 year. Shankol vaccine can be given to after 1 year old child. Dukoral is only given after 2 years of child, 2 years of age. So these are couple of your MCQs which you get direct between Dukoral and Shankol, and very frequently all these that I have written over here, these all are your favorite MCQ points. A follow through, a more stable kind of vaccine is also available, that is called as Uvicol. So Uvicol, it's still under the sanction phase, but many countries have already sanctioned Uvicol and they're using it. But on the contrary, you have this Dukoral and the Shankol or the Shankol vaccine, which are very commonly used. Out of them, which one is mostly used, Shankol or the Shankol vaccine? What happens is that as we are living in India, in case of cholera epidemics, do we give mass chemoprophylaxis or mass drug administration? It is not required at all, mass chemoprophylaxis. Why don't we require mass chemoprophylaxis? Because we already have so many carrier stages. To prevent one case of cholera, you will have to give mass drug chemoprophylaxis to 10,000 population, which you don't require at all. So for a country like India, launching these vaccines and taking this vaccine is not having any benefit. So who are the people who are going to use this vaccine? It is only a vaccine which is used for emporiatrics. What is emporiatrics? It is a science which deals with the travelers, with the travel study. So people who are traveling from cholera-free areas and people who are traveling to cholera endemic countries or areas like India, those people are the people who are going to take a Shankol vaccine. So Shankol vaccine, it's available in US, in Canada, in UK, in many parts in Europe. People take Shankol vaccine and then travel to developing country like India or in Africa, where you have many cases of cholera. So for emporiatrics or for travel medicine, we use these vaccines. Otherwise, for chemoprophylaxis, it's not at all required to take these vaccines because preventing, we might be the carriers of cholera, right? So for certain period. So depending on that, we have to take care of the preventive measures in cholera. Next we come over to is the diarrhea disease control program. Of course, this program is not a program that has a separate ministry or it has a separate infrastructure, separate targets. It's not that we have a separate program called a diarrhea disease control program, but it is one of the schemes or the major schemes which is associated with many other things. I'll just discuss with you so you'll come to know on this better that what you need to remember for your exams, the components of the diarrhea disease control program. The components could broadly be classified into two components. We can have a short-term component or a long-term component. The short-term component is primarily focusing on the diarrhea control. So what do we need to do in this? We want to have early diagnosis of the diarrhea cases and their prompt and good treatment. What to do about the long-term management of diarrhea control systems in India? So for long term, you have three broad components. First is to promote MCH care, because we think better mother or a healthy child will have lesser chances of diarrhea, right? So promoting the better MCH care. Then is promoting preventive care for diarrheal diseases. And third is to inhibit or prevent diarrheal outbreaks or epidemics in the country. So these are the three long-term components. So how would you do MCH care? That is the whole RCH program. We have already discussed that. How will you increase the preventive care in diarrhea or to decrease the diarrheal outbreaks? So that is not very simple, but that is very simple to understand. You will improve sanitation. Of course, it's simple and for me to say and simple for you to understand, but it is difficult on practical basis. To improve the treatment facilities. What do I mean by that? That means there should be healthcare provision at the village level. Asha workers should be knowing how to treat it. The Anganwadi workers should be knowing how to treat diarrhea cases. There should be improved immunization. So under this, we have launched the intensified mission Indradhanush 2.0, which is to cater for all high-risk cases, vulnerable cases, all slum population with 100% immunization coverage. That is under immunization. Also to improve nutrition of the children. So for that, we have given ICDS program, the Anganwadi program. You give them supplementary nutrition, Poshan Abhiyan. So many things are happening. Also to improve the supply. That's important because improving the supply of what? Supply of the ORS or supply of the zinc or supply of the vitamin A prophylaxis that we are giving. So improved supply of the micronutrients. Also to improve the rotavirus vaccine coverage. Currently, rotavirus vaccine coverage is pretty low in the country. So these all things would be there as part of the National Diarrhea Control Program components. And then just one last thing, again, you need to remember on a global scale, we have a global action plan for prevention and control of pneumonia and diarrhea. We already discussed this with the respiratory infections as well, that under 5 pneumonia deaths to be less than 3 per 1,000. We also want under 5 diarrheal deaths to be less than 1 per 1,000 live births. And pneumonia and diarrheal cases, the incidence of pneumonia and diarrhea cases to be decreased by 75% and stunting prevalence to be decreased by 40%. Compared to what levels? Compared to 2010 levels. And by when do we need to do all this? We need to complete this by the year 2025. This is the global action plan for prevention and control of pneumonia and diarrhea. And that's what the whole WHO system is doing. So with that, we have finished the topic on cholera and the National Diarrhea Control Program.